Okay, I think for now, I think we'll just get started just in the interest of time. I was would like to just welcome our two speakers today to do this presentation. Hopefully, Dr. D. Travolsi will be able to join us from Calgary. He's having some problems himself with also some technical difficulties, so hopefully he's able to help to connect with us. At Edmonton here, I have Dr. Kevin Bainey. Both Dean and Kevin have been co-chairs for our acute coronary syndromes expert working group for our cardiovascular health and stroke SCN for a number of years, and have led the work in terms of the development of this new reperfusion guideline, order set and guidelines. So in the interest of time, I may pass it now just to Kevin, and hopefully Dean will be able to connect in and help with the presentation. So Kevin, if it's okay, I'll pass it to you.
Yeah, great, thanks. I hope that everyone can hear me okay. So I'm presenting on behalf of myself as well as Dean for the STEMi myocardial infarction reperfusion order set that should be out, or that should have been released already. There's conflict of interest slide that comes thereafter, and as we all know online here that this is eligible for CME credits. And so here, participants here will improve diagnostic skills and treatment choices for individuals who present with an ST elevation MI. We'll describe the impact of the STEMi order sets and rural transfer guidelines on overall time to treatment, which I think is really important. We'll spend the bulk of the presentation identifying reperfusion strategies and particularly focusing on patients who would be eligible for fibrinolysis. And then we'll list the local treatment protocols and immediate transfer options. So, by way of background, this order set was developed by the ACS working group, and they are based on best evidence, and they were put together in consultation with multidisciplinary clinicians and departments. The whole point to these order sets are to try and standardize care across this province for best patient outcomes. These orders are for use on presentation of patients with STEMi and available to be adopted or adapted for local use, and for use with the provincial STEMi rural transfer guidelines as well. So this is a quick slide highlighting the number of STEMi patients that we see in the province of Alberta. This is taken from population health data from 2015 to 2016, and essentially shows us that we're probably treating about 2,500 ST elevation MI patients in this province each year, a substantial amount, and we all know on today's session that STEMi comes with a high comorbid risk as well as mortality. So a really important patient group for us to focus on and try and standardize care. So the orders outline will look at patient treatment and monitoring, identify reperfusion eligibility, determine eligibility for fibrinolysis. We'll walk you through how we choose a reperfusion option, and we'll also hopefully reinforce the idea that all of these patients need immediate transfer to a site that does have a cath lab, and that's where rapid calls come into play. Okay, so we've tried to make this order set as easy as possible to follow, and from what I recall, the actual order set really just comprises of 3 pages, but we have a bunch of appendices that are listed to help walk you through treatment of these patients. And these order sets really do, this order set really does differ from prior order sets in that we really have now tried to stratify our ST elevation MI patients based on age in terms of the use of fibrinolysis. So that's where this division comes into play, and I'll walk you through that shortly. So the appendices A, so to speak, looks at tenecteplase and enoxaparin protocol. B looks at TNK and enoxaparin protocol over the age of 75. The first one was less than the age of 75. The third one looks at TNK with unfractionated heparin in patients less than the age of 75. 75. The fourth one looks at TNK and unfractionated heparin in patients over the age of 75. And the last section really just walks you through anticoagulation doses. And you'll see examples of this coming up shortly. Okay, well, let's start with the beginnings of the order set. So really, for the STEMi reperfusion orders, we all know that in a patient that presents with a STEMi, we have to review and complete a 12-lead electrocardiogram, which is to be done as soon as possible. What you'll notice on these order sets is that there are timestamps that are located right beside these recommendations, and this is really to help for future in terms of research endeavors, and that's why we have these timestamps in play. And so the next section walks you through taking the initial vital signs. We also mentioned an intravenous saline access. The important point, probably the most salient point in this on this first page here, is the oxygen levels. So this is again according to best available evidence and has changed from previous protocols, in that we now recommend that oxygen only be given if SATs are less than 90%. So if you have a patient that has O2 SATs of 90% or greater, in fact, they do not require oxygen therapy. And again, that's based on a very large randomized controlled trial that was presented recently called Detox-2. And then we walk you through, of course, the aspirin bolus to be administered. We also mention about blood pressure and when to give sublingual nitroglycerin, recognizing an RV infarct. If you're hypotensive, you want to avoid that. I think this was a new recommendation of which we now require these patients to have defibrillation pads, given the fact that we know these patients are at high risk of developing ventricular tachycardia, ventricular fibrillation. We have a section that states monitor ECG and document arrhythmias, and then contact a physician as soon as possible if ongoing pain or hemodynamically unstable.
Can I just ask you a question? It's
Yeah, go ahead.
Kathy from Cochrane. In that order set, the order set that I have, which was 2017-06, still has the 94%. Should I be getting a newer version?
Yeah, that's a fantastic question, and thank you for that reminder. This was something that came to light as of recent, and so the subsequent order sets that will be ordered will have this change available.
Thank you.
Already.
Yeah, so the change has been made already, so any further orders of this order set will have that change in play. So, okay, moving on to the next page here, we have kind of walks you through now how to identify a patient with an ST elevation MI. So again, here this is walking you through how to identify a patient with an ST elevation MI. And essentially, you must, we state that you have to answer yes to all three questions in order to be eligible for this STEMi order set. The first one is there evidence of a myocardial infarction? And this walks you through how to diagnose an ST elevation MI based on the electrocardiogram. And this again is based on best clinical evidence, practice guidelines that we both have, or that our group has reviewed from the ACC-AHA as well as the ESC STEMi guidelines. So this is quite different, but essentially walks you through how to identify an ST elevation MI according to gender. In a male, it's if you have ST elevation greater than or equal to 2 millimeters in V2 to V3, or in women with ST elevation of 1.5 millimeters in V2 or V3. And then otherwise, in men or women, new ST elevation or ST elevation of greater than or equal to 1 millimeter in all other leads. And those have to be contiguous leads, and that's kind of outlined in the descriptor below. And for an isolated posterior infarct, it walks you through how to identify that. In men or women, new ST depression at the J point greater than or equal to 1 millimeter in leads V1 and V2, and ST elevation greater than 1 millimeter in the posterior lead V7 to V9. The second criteria is that is there persisting ST elevation and pain despite sublingual nitroglycerin? We have seen STs that have come down just with the administration of sublingual nitro, so that's important that there is persistent ST elevation despite giving sublingual nitro. And the third one is looking at patients who really do present within 12 hours of symptom onset, and there's a timestamp associated with that. Patients that present more than 12 hours, this order set does not apply to, as the treatment for those patients are quite debatable at present. If yes to all of the three questions above, it says to proceed to page 2, and then if no, then consult cardiology. So here, this just kind of walks you through, previous slide. This walks you through the eligibility for fibrinolysis. This order set really does focus on patients who are eligible, potentially eligible for fibrinolysis. And again, these are absolute and relative contraindications for fibrinolysis, incorporating the recommendations that were made from the ESC as well as the ACC-AHA. I'll let you peruse those recommendations, but for the sake of time, we'll jump to the next slide. Okay, so now we're at the point where we say, okay, we've identified an ST elevation MI patient. They, let's say, do not have any contraindications to fibrinolysis. Then we decide upon what our reperfusion strategy is. And so on the right-hand side of that slide, it says, we do consider fibrinolysis in patients whose goal of 90 minutes to PCI cannot be achieved. And if that is the case, fibrinolysis should be administered. And then we have the various regimens that we would give stratified by age 75. So it's our preferred approach would be TNK with enoxaparin, recognizing that enoxaparin does have some limitations in patients who are morbidly obese or who have renal impairment. But essentially, we do know from all available evidence that a TNK enoxaparin strategy is better than a TNK unfractionated heparin strategy, but we do give you the options for both. So here, if you're less than the age of 75, it's really the standard protocol that we've all been used to, and I will walk you through that with a case example. If you're over the age of 75, then we strongly endorse a half-dose TNK regimen. This is quite new. This is based on local evidence as well as subgroup analysis from a big, large randomized study called the STREAM trial, and we've decided to embrace this universally across the province. And then for fibrinolysis for patients with TNK and unfractionated heparin, it walks you through what to do in patients less than the age of 75 versus greater than the age of 75. And again, greater than the age of 75, it's a half-dose TNK regimen. Let's say that you're not a candidate for fibrinolysis, so you have an absolute contraindication, or we think that you can get that patient quickly to the cath lab. Then we would go down the primary PCI strategy with the goal of 90 minutes to PCI, where that time should be achieved to undergo primary PCI, or in patients who are really sick, who are in cardiogenic shock or hemodynamic instability, we do prefer a primary PCI strategy, but recognizing that this is not set in stone, that you will have patients who are really, really far away that you just can't get to the cath lab even in shock, and lysis may be an option. But when you get into that domain, it's really best to speak with a cardiologist on call. Anyways, continuing with primary PCI, we now strongly endorse ticagrelor as our dual antiplatelet regimen of choice for primary PCI, and that's a 180 milligram dose given orally. But if unavailable, we have a second option of Plavix 600 milligram oral loading dose. And then we walk you through what anticoagulant to give. And so our preferred anticoagulant is enoxaparin at 0.5 milligrams per kilogram, direct IV times 1 dose. And then if anticipating more of a delay in terms of transfer, then that's where you need to consult cardiology. If enoxaparin is not given as your anticoagulant of choice, then your other option is unfractionated heparin at 70 units per kilogram, direct IV, and then we'll walk you through that in terms of one of the appendices. And then this is really key. Once you have decided upon your reperfusion strategy and initiated treatment, don't wait. You need to call Rapid right away and get your patient transferred to a site that ideally to a site that has a cath lab that is available for backup. There's the days of waiting to see if a patient reperfuses no longer exist. The evidence to date strongly endorses these patients be transferred as soon as possible. And that's where the call to Rapid comes into play. There's a whole bunch of documents that need to be sent to support documentation when planning for transfer, and there is a timestamp that is available there for first ECG that we do require, again, important for us from a quality assurance perspective, but also from a research standpoint as well. Okay, so I'm going to walk you through a few cases, primarily focusing on the reperfusion strategy and the anticoagulation and or fibrinolytic agent used for these cases stratified by age. So the first case is going to look at a STEMi patient who is less than the age of 75 years and is going to receive fibrinolysis. So a 61-year-old person who presents early with symptoms and presents to the triage desk looking quite bad and had a prior MI in 2004 with a bare metal stent, and a 12-lead electrocardiogram is done right away and shows inferior ST elevation. Again, this patient is less than the age of 75. Again, patient 61 years of age, and presents early. So this is an ideal patient that would be a candidate for fibrinolysis. And so this again walks you through, in terms of one of the appendices, on how to administer the fibrinolysis regimen. So here it basically, I know the writing is pretty small, but essentially monitor the patients neurologically, then go ahead and administer your enoxaparin 30 milligrams IV, and then prior to administration or administer the enoxaparin IV prior to the administration of TNK if possible, and then go ahead with TNK, which is going to be a regular dose strategy of TNK with a maximal dose of 50 milligrams, and that's weight-based. And then refer to it just kind of walks you through how to do that accordingly. And then after that, we want you to administer enoxaparin subcutaneously at 1 milligram per kilogram sub-Q. And that's to a maximum dose of 100 milligrams. Then we go on to our antiplatelet strategy, which is a bolus of clopidogrel, 300 milligrams orally. And this is a really important point, that with fibrinolysis patients in STEMi, we do not have the evidence yet for ticagrelor, and thus we have stuck with clopidogrel as our choice of dual antiplatelets for patients who are receiving fibrinolysis, a really, really important point. And then post-fibrinolysis, again, do ECGs accordingly at 30, 60, 90 minutes. Of course, you're not going to wait to do that. Hopefully you've had your patient transferred by that time. And of course, monitor your patient neurologically. And the whole point to that is with TNK, there is a small risk of intracranial hemorrhage, and you want to identify that early with neurological vitals. This is a case, second scenario, in a patient who is over the age of 75 and now is going to get fibrinolysis. And this is obviously a really important case because this has very much changed from prior recommendations. So this patient is 88, and presents with a 3.5-hour history of chest pain, a bit short of breath, and is treated with aspirin and some nitro with a little bit of relief, but is not looking, too well in the emergency department. Has a history of hypothyroidism, and you've again done a 12-lead electrocardiogram as quickly as possible and have identified an ST elevation MI. We'll walk you through how to administer fibrinolysis in this patient. Now, let's say this patient is in, I know somebody from online here is from Cochrane, and perhaps maybe it's going to take you too long to get that patient to Calgary, and then you would really, in that point, you'd consider giving fibrinolysis despite the fact that the patient is 88 years of age. What's critical to important here is that it's a half-dose regimen with a modified anticoagulant and antiplatelet regimen. Again, this is evidence-based, and according to the evidence shows us that the intracranial hemorrhage rate in these patients is identical to patients who undergo primary PCI. And an important qualifier to that is that it's extremely low. So here, what it states, okay, you monitor the neurovitals. You do not give an IV enoxaparin dose. You go straight to TNK, and the dose of TNK that's given is the half the regular dose that you would give, and that is identified in the table. Then, after you've given the TNK, it is important to give enoxaparin sub-Q, but again, a modified dose of sub-Q enoxaparin at 0.75 milligrams per kilogram to a maximum of 75 milligrams. And then our antiplatelet, again, we stick with clopidogrel, but we do not give them a 300 milligram bolus. We just give them 75 milligrams daily. And then, of course, as similar as what we saw previously, monitor the ECGs accordingly, and neurovites, which, of course, what's integral or extremely important here is getting your patient transferred as quickly as possible. So now, so this is just walking through your enoxaparin dose that you would administer subcutaneously based on weight. And this is one of the appendices that's listed in the order set. Okay, and this now is looking at a TNK and unfractionated heparin in patients less than the age of 75 years. And so let's go back to, for instance, our first case, the guy that was 61, but you decide to give unfractionated heparin as opposed to enoxaparin. And again, this appendices walks you through how to do that with an unfractionated heparin bolus of 60 units per kilogram IV, your TNK given at your regular dose, your normal dose of your loading dose of clopidogrel, and then your infusion of unfractionated heparin, and then, of course, preparing your patient for transfer. And here, this just again walks you through in terms of one of the appendices on the IV dosing strategy to give your patient with unfractionated heparin, bearing in mind that there's a maximum of 4,000 units that you can give based on weight. Okay, so now we're going to go to the second patient who is 88 years of age, and you cannot give enoxaparin. Now you decide to do unfractionated heparin with TNK. And again, what we do, we say do not give any bolus. We start with neurovites to be monitored. We do say unfractionated heparin, 60 units per kilogram bolus times one dose, and that's 60 units per kilogram. Then we go ahead with our TNK strategy, of which we again strongly endorse a half-dose strategy. Followed by that, it's clopidogrel 75 milligrams daily. We avoid the loading dose of 300 milligrams. Then we set you up with an unfractionated heparin infusion. That again walks you through how to do that, and then monitoring ECGs and sending your transferring your patient as quickly as possible. Okay, so now so that's the bulk of the fibrinolysis treatment strategy. Let's say you have a patient where you are strongly endorse a primary PCI strategy. So this is a 44-year-old guy who presents in a wheelchair to the triage desk with a 5-hour history, so a bit longer of an ischemic time, and is reporting some shortness of breath, an allergy to penicillin, has a family history of coronary disease, dad having bypass surgery, and a social drinker, and otherwise he's stable hemodynamically, and he has a history of asthma. So this patient, you've done a 12-lead ECG, and you identify that there is ST elevation and having ongoing chest pain. So you've decided to undergo a primary PCI strategy, so I'm going to walk you through how to do that. Of course, at this point in time, it's important that you've called through rapid and have gotten into contact with either the cardiologist on call or the interventional cardiologist on call. And now you've decided in conjunction with the cardiologist on call that you're going to undergo a primary PCI strategy. The goal again is to get your patient there as quickly as possible. So goal of 90 minutes to PCI, or if the patient is hemodynamically unstable, as mentioned before, we endorse a primary PCI strategy. Here again, ticagrelor 180 milligram bolus, and if unavailable, then the other choice is clopidogrel 600 milligram bolus. And then for anticoagulant strategy, again, we endorse an enoxaparin-based strategy, 0.5 milligrams per kilogram IV dose times 1. And if anticipating a delay, then consult cardiology for further anticoagulant management. If enoxaparin cannot be given, then unfractionated heparin at 70 units per kilo, direct IV. And again, we have an appendices that walks you through how to do that. And that's here. So again, this is the unfractionated heparin IV bolus dose based on weight of 70 units per kilogram. And I think this table was cut off, but essentially just walks you through how to the dose to give, beyond or up to 82 kilograms. So this is an important slide that I think endorses what to do in the rural setting for an ST elevation MI. And in the rural setting, as we all know, it's going to be really hard to get a patient in a timely fashion for primary PCI. And that's why these order sets really do endorse, if at all possible, a fibrinolytic strategy if you can't get your patient to the cath lab in a timely manner. And so in the rural setting, if it's a STEMi, you obviously right away go through the contraindications to fibrinolysis. If there's a contraindication, you need to call through rapid and speak with the cardiologist, interventional cardiologist on call to decide what to do. If there's no absolute contraindications, then we state that and the STEMi presentation is greater than 6 hours. Then we know in that scenario, fibrinolysis is not as effective, again, in a patient who's having more than 6 hours of symptoms. And there you'd want to call through rapid and speak with the cardiologist on call, because maybe, although we say that fibrinolysis is not as effective greater than 6 hours, it may be still an option, but at that point in time, really consult cardiology is critical. But let's say your patient presents less than 6 hours and is a candidate for fibrinolysis, then we would endorse going ahead with fibrinolysis with a delivery goal of less than 30 minutes. What is also integral in that algorithm is that you get your patient transferred as quickly as possible, and that's where the call to rapid comes into play. So thank you. I was intentionally trying to finish a little bit early because I wanted to open it up to the audience for questions. I think, like I said, we've tried to make this order set as simple as possible with the appendices and hopefully it will be widely adopted across the province. So open it up for questions.
Hi, it's Cochrane. It's Kathy Dobson calling. Would you be able to just give us a little clarification on the suspected or known or suspected renal dysfunction or morbid obesity? Just some brief guidelines on that, because that's very new for us.
Yeah. So, fantastic question. I would say that in terms of renal dysfunction, it would be really a creatinine clearance of less than 30, where I'd be very hesitant or concerned about giving enoxaparin in that setting. And so those are the patients, creatinine clearance or GFR of less than 30, that you would really stay away from giving enoxaparin, or on a patient who's on dialysis. In terms of morbid obesity, morbid obesity really, of course, is kind of debatable. But really, when you are 100 kilograms or more, is when we start thinking that perhaps you may want to stay away from enoxaparin and consider an unfractionated heparin-based strategy. Any other questions? And I don't know if Dean has been able to log in. Again, I think there's been some troubles through telehealth in Calgary, and so of course, if there's any questions or concerns that you come across thereafter, this slide does provide you with our email addresses, myself as well as Dean, and we're both open to any questions or concerns. Again, the mission of this order set is really to try and standardize care across this province, which we know will improve patient outcome. Again, we've really tried to align this with best available evidence. Does anyone have a question about the half-dose TNK strategy? That's obviously very new, I can just anecdotally tell you that from our use here in Edmonton, we've seen quite a bit of success with really minimal, if no, intracranial hemorrhage. So really does support what the evidence has shown us in the elderly patients.
Hi, I have a question.
Mm-hmm.
Can you hear me?
Yeah.
So I have the older, I'm from Lac-La-Biche, and I'm just looking at the older order set as well. So except for the one change that you talked about earlier with, sorry, I'm flipping around my pages here, but the change about the O2 sats, is there anything else significant that we should be swapping out our order sets right away to the newer version?
Yeah, I think the half-dose TNK strategy in the elderly, I think, is a big change. The other big change was the definition of an ST elevation MI, which has changed from the prior order set, the oxygen saturations, as you mentioned. Sorry, I have the newer version, but just a different version that doesn't have the O2 sats, because it does have the half-dose. Oh, okay.
Yeah, it does. So I'm just wondering if the newest version is significantly different, that we need to change them right out. Because I do have the newer version.
Right, correct. Okay, I understand. So the answer would be no. The only so we had just recently made this change to the O2 sats. So the next versions that you order, the only change will be the O2 sat.
Will be that. Okay,
yeah.
Perfect. Thank you.
Hi, Kevin. Can you hear me?
Yeah.
Oh, good. Dean apologizes. This is Claire from Calgary. He could not get online with the new scheduling format that they were endorsed. I do have a question, but just want to clarify about the time of symptom onset, 12 hours.
Yeah.
So are we saying to give TNK right up until with 12 hours of onset, or after 6 hours they should be consulting for further direction?
Okay. Yeah, great question. So to clarify that answer, first of all, greater than 12 hours, we know that essentially fibrinolysis will not be effective, and it's debatable even if primary PCI is effective. But if greater than 12 hours, really, fibrinolysis is not an option, perhaps primary PCI. But again, this order set really, at that point in time, you'd be consulting cardiology. Within 12 hours, we know that the earlier that the patient presents, the more success you will have with fibrinolysis. And so at that 6-hour interval, the order set endorses that if you present within 6 hours, that's really the time interval where fibrinolysis will be the most effective. In a patient who presents greater than 6 hours, you're probably at that point in time starting to think, well, you know what, primary PCI may be a more effective strategy, even if it's perhaps a little bit delayed compared to fibrinolysis. But that is subjective, and it's contingent or dependent upon how far away you are from a site with a cath lab. So I'll give you an example of, let's say here, a patient who presents in this scenario in Grand Prairie. It's just impossible to get this patient here in a timely fashion for primary PCI. So even in a patient who presents greater than 6 hours with symptoms, I would still consider giving fibrinolysis. So when it gets to that kind of subjective gray area, that's where the call through rapid comes into play to speak with a cardiologist. Does that clarify your question?
Absolutely. That's what I was thinking. I just couldn't determine from the order set where it said greater than 6 hours consult rapid in cardiology.
Yeah, no, that was, that's really just from that rural slide that we had mentioned. But yeah, I think, it's all of the answer to your question is, there's a big gray zone. And when you embark or enter upon that gray zone, the default is really to call through rapid and speak with a cardiologist on call.
Perfect, thanks.
I had put up just a moment ago, in order to receive your STEMi credits, you need to contact Heather Michaud. She will give you the certificate of attendance, and I understand that's what you do submit for proof of attendance for this event, and you can receive your credit. So please get a hold of Heather for that certificate. And also, if there's some general questions that maybe aren't specific clinical questions you may need, Heather is also an avenue for you to get a hold of the rest of the teams, and the administration if you have some technical, non-clinical questions. Heather can direct you to the right person as well. So as soon as that website's available, we'll have that posted. I think too, we'll probably see if we can have this also included into the next, the posting of where to find the recordings in the next newsletters that come out for both those networks as well. And this is what our websites look like. It's the just for clarity about which website, it's the external websites, not the Insight websites. Insight would not be accessible to everyone, particularly physicians that aren't AHS, don't have AHS logons. So it will be posted on the normal internet website for AHS under the SCNs, under the cardiovascular health and stroke SCN and Emerge. And just a message from Dean, he was able to connect. Any other questions from any other sites? I did have just a few more technical points to also inform the group about. As you are most likely aware, with the upcoming CIS, there's been a lot of work around order sets and placing these onto the new knowledge viewer, it's called, in terms of where you can access the order sets. And so we have worked with the emergency SCN group, and the content leads from emergency and our network have worked closely together. This order set has been endorsed by the Emerge SCN and the Emerge knowledge lead for the CIS development. So once done with these orders, this order set will be available on that website. It will be available through the knowledge viewer, and this will be the order set that will be used when it comes time to upload to CIS. In addition, we do have some educational materials, obviously, like for example this recording from today, as well as some educational slide decks for nursing in particular that will be available to accompany those order sets once it's uploaded onto the knowledge viewer. So when you if and when you do want to access the sites, this order set on that site, you will also have the accompanying educational tools. So it's very handy province-wide to have that consistency and availability of that kind of educational tools to train new staff and new people. So the question is, sorry, this is coming through the Skype here,
okay.
And I don't know that anyone could hear that.
Okay.
The question was, they use ECPG, and they were wondering if that will be updated anytime as well. I'm not sure the answer to that question. I would assume that with the knowledge viewer, I don't think anyone here in the room probably knows the answer to that in terms of ECPG process work, but I can certainly look into that. But I believe what's going to be posted on ECPG should and would need to be in alignment with what's going to be taken up through the CIS work and the knowledge content. So I can certainly look into that. If you want, I can take your name and just get back to you with an answer on that. And so it's ECPG update. And okay, great. Yeah, he just made a comment. There's the old one is still on ECPG, and there's a number of sites that would likely still be accessing that. So that's a good point. We need to make sure that this order set is uploaded there as well. Yeah. Any other questions? If no other questions, then thank you everyone for joining this telehealth event. And again, if you need more information, I'll just put up the slide again and where to access the actual form numbers and whatnot. So thanks for attending today's event, and we will sign off.